PRDS, pleural mass, chest wall mass, or ECMO. If the trachea is pushed away from the opacified side, we can consider pleural effusion, diaphragmatic hernia or rupture, or a large pulmonary mass. So we'll go through some cases. So for the first case, we have a 50-year-old male with difficulty of breathing, and his AP radiograph shows the total whiteout of the right hemithorax. And if we look at the trachea, will notice that the trachea is pulled towards the opacified side. As we said previously, these are our differentials if the trachea is pulled to the opacified side. And could this be a case of pneumonectomy? Well, the patient doesn't have his neck, and we don't see post-surgical changes such as surgical clips. Could it be total lung collapse? Yes, it could be a case of total lung collapse. And then would it be a genesis or pulmonary hypoplasia? Usually in these cases, it's well, we would see more long-term changes such as marked decrease in size in the opacified side, hemithorax, and hyperinflation of the contralateral side. And also, it's important to correlate it with the patient's history. So this is actually a case of total lung collapse, secondary to a bronchogenic cancer obstructing the right main bronchus, causing collapse of the right lung. Next is a 78-year-old male with weight loss, anorexia, and vomiting. And we can see again a opacified right hemithorax, and the esophagus, the trachea is shifted towards the right side as well. And if you'll notice, there's a distinct air fluid level, and what could cause an air fluid level? So normally we could think of hydropneumothorax, but in this case, we will note that the air fluid level does not reach to the lateral chest wall, and also that the trachea is shifted towards the opacified side. So this is unusual for a hydropneumothorax. So if it doesn't reach the lateral wall, we would be thinking that there's something limiting the fluid. So could it be due to abscess, or is it a lung cancer with central cavitation, which can also develop air fluid level? But if we look at the position of this, it's near the apical region, so it's unlikely to obstruct the right main stem bronchus if ever it is some sort of mass. So what could be causing this whiteout and collapse of the right lung? So this is actually a case of achalasia, and the enlarged portion with the air fluid level actually represents a markedly dilated esophagus filled with a large amount of debris and atelectasis of the right lung. So this is consistent with the whiteout of the right side and the shift of the trachea towards that side. So it's important to think not only of the structures in the lung, also the surrounding anatomical structures in that region, as in this case. Next is a case of a 30-year-old female post-intubation. And this case is pretty straightforward if we look at the position of the ET tube. It's positioned with its tip in the right main bronchus. And this results in the complete opacification of the left lung because air is not going to the left lung, so it has collapsed. And we'll notice the trachea here is also pulled towards that side, the opacified side. This is due to collapse of the whole left lung due to a malpositioned endotracheal tube. And we'll notice even the mediastinum is actually shifted towards the left side in this case. Next, this is another case wherein we would see is shifted towards the opacified side. So patients that are status post pneumonectomy. So I'd just like to discuss some of the changes that we'd expect after pneumonectomy. So here in the first image, we would see the mass, and then this second image is immediately post pneumonectomy, and you'll notice that the side that was pneumonectomized is completely filled with air. So within the first 24 hours, usually we just see that this side is filled with air, but after this period, we would see that it is becoming filled with serosanguinous fluid. Usually, it increases by around two rib spaces per day. And by the end of months, there is complete obliteration of that side, a pacification with the fluid. Eventually, usually there's also a chest drain on that side to drain the fluid, and eventually the fluid is resorbed or drained, and we would notice that there is um, a pacification of that side also, but this time it's because of the collapse in the lung. If there's no more lung, so that side decreases in volume, and then we would notice a shift in the mediastinum and in the trachea towards that side. And the maximum shift is usually at 6 to 8 months. So it would look like this, where we would see that there's a pacification of the right hemithorax, and you'd notice there's loss of volume in that side. The black arrow points to the trachea, which is shifted towards the side of the volume loss. And we would notice here post-surgical changes. The red arrow points to a missing fifth rib, which was removed during the operation, and the white circle shows surgical clips. Next is a case of a 40-year-old female with long-standing shortness of breath. So we'll notice that the left side is, well, almost completely opacified, and the right side is markedly hyperinflated. You'll also notice the left side shows a decrease in volume of the left hemithorax, and you'd notice a crowding of the ribs. So this is actually a case of pulmonary aplasia, and this was actually because the patient has long-standing shortness of breath. This is actually a congenital case of pulmonary hypoplasia. Next, we have a case of a 30-year-old female with fever and cough. And we'll notice the left hemithorax is opacified. And the trachea, if we look in this case, is midline. So these are our considerations for a trachea that is centrally located. If you'll notice, there are very evident air bronchogram sign in this patient. So this is actually consistent with total consolidation of the left lung. And in the right lung, actually, if we'll see, there are also patchy ground glass densities. So, and if we correlate it with the history of this patient, this is clearly a case of pneumonia. This is a patient status post mitral valve surgery. And if you look at the trachea, it's not very evident, but if you see its midline, and this is actually a case of pulmonary edema status post surgery, pulmonary edema in the right lung, which was also the side where the surgery was done. Next is a case of a 65-year-old male with progressive shortness of breath. So we can see the left lung is a large portion is opacified, and if we look at the pleura, it appears diffusely thickened, and this is it has sort of a nodular contour, and the lung is decreased in volume. So this is actually because of a mesothelioma, which is encasing the left lung. So this is one of the causes also of an opacified hemithorax that has a trachea that's central in position. Here we have a 15-year-old female with chronic dry cough, shortness of breath, and weight loss. And if you'll notice, the left hemithorax is opacified, and the trachea here is actually shifted to the right, away from the opacified side. So previously we said that tumors involving the chest wall will cause trachea that is centrally located. So this is actually a tumor of the chest wall that is Ewing sarcoma. So normally, chest wall tumors will have a midline trachea, but if they are this large and if they are invading into the lung tissue, large extrapulmonary invasive soft tissue masses can also cause a shift of the trachea sometimes, as in this case. So again, this is a chest wall mass or Ewing sarcoma. And if we look at the CT of this patient, you can see that there's a large mass with hemorrhage, necrosis, and cystic changes and invading into the chest, invading past the chest wall. So this is causing the shift. Next, this is another case wherein the hemithorax is opacified and the trachea is central in position. So we can see the devices on this patient. So this is actually a ECMO device. So with ECMO, we normally expect lung opacity to increase because when patients are shifted to ECMO, the ventilator settings are changed, they are lowered, and we would expect collapse or a partial atelectasis in that lung, which is causing the increased opacity. However, if the opacity is continually increasing, we would also consider other differentials. And one of the risks in ECMO is hemithorax because these patients are placed on continuous anticoagulant therapy. So although we normally expect an increase in opacification once ECMO is started, if this continually increases, we should also have suspicion and consideration for other complications such as a hemothorax. Next is a 65-year-old female with dyspnea and known lung cancer. So we can see a opacification of the hemithorax. And then here we can see that there is a shift of trachea away from the opacified side. And we can see that the trachea is outlined in blue going to the left, and that the azygoesophageal recess, which is outlined in yellow, is also shifted away from the opacified side. And you'll notice that the rib spaces, which are outlined in red, you'll notice that the rib space on the opacified side is actually increased. So there are splaying of the ribs on the right side. So this indicates that there is something there causing a mass effect. And this case actually turned out to be a case of malignant pleural effusion, a large amount of effusion on the opacified side. And normally, when there are only small amounts of effusion, we have associated it with the classic meniscus sign, as in this case. But when effusions are very large, we may not see this meniscus sign, and it might just appear as an opacified hemithorax. Also, if patients are in the supine position, there is a redistribution of the fluid towards the dependent areas, and we also would not appreciate the meniscus sign. And it may just appear as a veil-like increased density over that side of the hemithorax. So in cases where pleural effusion is unilateral, as in this case, especially when they're this large, we should be alert for differentials, that especially concerning malignancy, because malignant pleural effusions can present unilaterally, as opposed to, for example, pleural effusion from congestive heart failure, which we would normally expect to be bilateral. Other causes of unilateral pleural effusion include infection, hemorrhage, or chylothorax. Here's a case of an 8-week-old girl with acute respiratory distress. And if you'll notice, there is almost total opacification also of the left hemithorax. The trachea is shifted away from the opacified side. And if you notice, there are gas locules of gas in that area, pointed by the gray arrows. And we would consider these differentials in cases where there's an opacified hemithorax and the trachea is shifted away from that side. And actually, this is a case of diaphragmatic hernia. And these gas pointed by the gray arrows, if we look at it on CT, we can see that this is actually representing the herniated bowel through the diaphragm. So again, when we see a patient with an opacified hemithorax, we should look at the position of the trachea, and these are the considerations that we have for these patients, and these are also the conditions that we discussed previously. Thank you.
Thank you so much, Kevin. Okay, so I like your approach that when you see an opacified unilateral hemithorax, you look at the side, the laterality, and then focus on the airway. So you gave the differentials on how to approach them. Very good. Ngayon guys, marami pang mga densities on the lungs that I would like you to be very particular about. Yan. You know guys, aside from pneumonia, pulmonary edema, you can identify that very clearly sa x-ray. And hindi mo kailangan i-end or eh. Well, siguro pulmonary edema and pneumonia, when it gets really dense on the x-ray, bilaterally especially, yon, sige. Pero I would like you to identify yung mga curly B lines, curly A lines, because that would help you say na, oh, this is beginning interstitial edema. Makakita sana ako ng ganong mga mata na even without the consultant telling you na, ay, edema na to, kayo mismo at the very start, di ba? Interstitial edema, you can automatically identify that. Medyo hindi natin na-identify yun madalas, but I hope you are more focused this time. Kasi before you get the bat wing classical appearance, bat wing, butterfly appearance, you get muna yung mga peripheral thin lines, yan, mga curly B lines. Learn to identify those. Ano pa? Subpulmonic effusion. Nakakakuha tayo ng mga, kung mapapansin ninyo, nakakakuha tayo ng radiographs that has asymmetric domes of the diaphragm. The right diaphragm is excessively higher than the left or the other way around. Try to give the differential of development of subpulmonic effusion, proceed to ultrasound. Gawan natin ang mga reports natin ng yung thought process nyo, you see this finding, you give your description and then advice. What do I mean by advice? Typical na yung follow-up x-ray or close monitoring. Mag-advise kayo ng ultrasound correlation is recommended. CT scan with contrast is recommended. Yan. Mas makakita tayo ng mas maraming ganyan. Kasi practice nyo na to eh. Pagka kayo consult, sa inyo lalapit mismo yung mga clinician na yan. So, practicein natin ngayon pa lang yan, guys. Ha? I gave Benjo the journals. It's how to read critically ill patients, chest x-ray. 3 journals yan. So, composed of from pulmonary edema, pneumonia, thoracic devices. Ayun. Dapat mas keen tayo sa positioning. Dapat Alam natin when to alert the clinicians, mga malposition tubes, yan. Okay, guys? So, I expect, Chester, next week,
Yes,
oo,
next Friday.
pag-usapan natin yung, susunod, oo. Puro x-ray tayo para kung magagawan ninyo ng mga signs, mga x-ray signs, pasasamahin natin yung mga BOB participants kasi lumalabas din yung mga x-ray signs dito
Okay.
sa 15 minutes. Ayan, 15 minutes, 20 minutes tapos tayo, no? Kevin, excellent. Thank you so much.